MaCalus Hogan. I'm from the University of Pittsburgh Medical Center. I'm looking forward to speaking to you today on the UPMC experience with bundle payments and a little bit from the rehab perspective on our experience. Here are my disclosures. I have no relevant conflicts with this talk. Background of the CMS and health plan bundle programs, a little bit on our program evolution, how we've moved from a mandate to a directive to the Centers of Excellence, and a little bit on the birth of the Centers of Excellence for us here at UPMC. Healthcare, we all are speaking about it regularly, rapid evolution. It's a transformative time right now. And it's a challenge. There are federal and state regulatory challenges and changes. Vertical and horizontal integration is necessary, but also presents challenges from time to time. A number of disruptive new entrants from the standpoint of IT, technology, also the revenue compression, payment reform, the rise of consumerism and how we deliver care and how do we get to patients. Reimbursements are more and more going to be based on quality, and quality is assessed by outcome, and that's the future. Elective hip and knee replacements. This is what I like to describe. Orthopedics is one of the big three. When we think about the large expense for a CMS and for a number of payers, it really lands in the musculoskeletal realm, also the oncology realms and the cardiovascular realms, and then those that associated with that. And so with hip and knee replacement, it's a common procedure, moderate acuity, standardized and quite significant evidence and certification regarding that evidence. It's very patient-centric and quality is driving it. Comprehensive, high reliability of outcomes, however, though complications do occur, and it's very much is and should be, if not in your environment, pathway driven. And it does fall well within the value-based equation and the quadruple aim, really, and that's speaking on quality and cost. And for us, we really want to be excellent. A little bit of an evolution, though, where while others around the country were actively involved in programs such as BPCI and the bundle payment care initiatives, we actually within our organization had a pilot program, which was a shared savings program with the UPMC health plan. This program ran for the better part of 2 years, and it was really focused on inpatient stay, discharge to home, total hip, relatively uncomplicated, low acuity, total hip and total knee replacement. We learned a great deal during that pilot program, and we were in the process of going through those learnings and that evolution when what occurred next. We're talking more and more about the burden of osteoarthritis. When we really look at 30 million US adults who have osteoarthritis at some point, and the financial implications of that. In 2013, being 304 billion, medical costs, 140 billion, lost wages, 165 billion. And so we anticipate this number to continue to rise. And this is one of the main drivers that led to the Big Bang. CJR, the Comprehensive Care for Joint Replacement Model, becoming the first mandatory bundle program under CMS. And what did this mean? So for us, we were happy that we had actually engaged in some way in a quality care pathway-driven program with our health plan. But this was a big bang and a big shock for a number of environments and hospitals. And we had a lot to learn here at UPMC as well. And so what is CJR? It's a surgical episodic bundle, procedurally driven. It was based on inpatient admissions, all related care covered. It was Medicare fee-for-service. And it was really focused on that 90 days post-discharge. And this really, quite frankly, is what really engaged the post-acute care environment. Hospitals bared all the financial risk. All providers and suppliers would bill and be paid as usual under the Medicare payment system. But then this was when it was launched in April 2016, 5-year program with an original end date in December of 2020. We all know now that was extended due to COVID-19, but it was the first and still remains to now to be the only mandatory CMS program. Here within UPMC, in our environment here in Pennsylvania, we had a number of hospitals. All the ones you see here in this more salmon color were in that original mandate. And also our joint venture facility, Butler Hospital, was also within the mandate. So we had a number of facilities impacted by inclusion in this program. When we really looked at this, we also had the same time in fiscal year 19, greater than 5,000 hip and knee replacements. 58% were done within UPMC facilities, but as a large health plan and payer provider, a large regional health plan with 40% market share here in Western PA and Central PA, 42% of our joints were going to non-UPMC facilities. So what we really wanted to do is how can we align what's happening in our facilities with also what's happening with our health plan membership? How can we become one UPMC through this program? And as we really looked at this, our health plan patients plus CMS patients, there was a substantial volume of patients to leverage to really drive important clinical change. So our response included, we built on the foundation of our total joint replacement pathway group, which included a number of nurses, physicians, surgeons, a number of our partners in the rehabilitation space, as well as our administrative partners in finance. We engage the UPMC surgeons and providers, irrespective of affiliation. Across our UPMC facilities, 30% of our care is provided by private practice practitioners. And we really aligned our teams across the enterprise. And we also aligned with our shared savings programs. So when we looked at the main markers for the CMS program, it was HCAHPS at the hospital level, complication rates, and patient-reported outcome measures. And for UPMC, those were also very important. So we mirrored our program within UPMC to meet that same bar. Physician alignment was key. We made information accessible to everyone. Expertise was then leveraged across the enterprise, and facility surgeon champions were identified across all of our hospitals, and this included employed and private surgeons. When we look at the essentially deployed orthopedic navigators across all of the main sites that were impacted by the program and included. We developed a pre-op operative assessment and also a prehabilitation program where patients would go to rehab for a visit prior to surgery, but also was inclusive in their episode of care. But we felt this actually helped drive outcomes and manage the discharge disposition. Patient education expectations, we really doubled down on our education programs. We developed a reversible risk module and approach for optimization of care. We developed post-acute preferred partners where we, as facilities, went into when patients did need skilled nursing or rehab, we had preferred partners that our providers and hospitals would refer to. And also post-discharge communication and readmissions. And we had a composite scoring around quality. We developed a patient-reported outcomes registry platform. And we really made strategic financial investments, including in our navigators and in our outcomes platform and registry platforms to drive success. And we also developed, again, leveraged our UPMC health plan shared savings partnership. When we looked at this, we then broke down the care continuum and really broke this down, whether it be a phone or in person, the estimated touch points for patients. And it really follows this care paradigm from the preoperative space all the way through the postoperative space. And this is also what allowed us to really maintain this program in a robust and high quality fashion, even during the time of. So this diagram here really defines our program. It really speaks to how we deliver care, what our focus has been from the beginning of the joints bundle, all the way now going into the CMS extension, as well as managing things across the preoperative, perioperative, inpatient stay, as well as post-discharge and transition of care environments. As you can see in the core of this presentation, physical therapy evaluation on the operative day is key, and then ongoing PT twice a day. So when we think about our modifiable risk, we look at things from a standpoint of fixable, what can we improve and what is chronic, and making sure that we acknowledge these and work to optimize patients across the board. We also collected patient-reported outcomes across the continuum of care from their prehabilitation visits through the perioperative period, as well as in the postoperative period through our partners at Center for Rehab Services here at UPMC. And when we look at department readmissions, we developed a total joint replacement U-turn program to essentially help optimize patients avoiding the ER. But when they did go to the emergency department, how can we work to get them the appropriate safe disposition that does not always have to require admission? And one thing I would like to just highlight when you look at the disposition slide here, when you go down 2 levels down, you look in with our developed a process to provide PT evaluations in the ED if need be, if it can also help facilitate the person getting back to a safe environment without having to be readmitted. We also wanted to know how we compared across the country. So we enrolled in AJRR, and we now in surgical and implant data in this platform. We developed a total joint replacement quality card, which can be tracked by physician, by facility, and this covering a number of things. And we felt very important, managing length of stay, managing discharge to skilled nursing facilities, and the proportion of our patients that are receiving home health versus skilled nursing versus inpatient rehab as a part of our standard tracking. Furthermore, we have an extensive dashboard that, again, is always monitoring these discharge spaces, and disposition rates were always a key part of our program. When we looked at our success over time, we've trended down with length of stay. This has been consistent that we've seen around the country, where our length of stay now is closer to almost less than maybe just slightly over 1 midnight, around 24 to 36 hours. When we look at our discharge disposition, we really had a very strong and aggressive, we engaged with our physical therapy partners and home health partners, and we've seen this rapid increase in utilization of home health, as a number of people have seen around the country. But for us, we didn't cut out PT. We felt PT was a critical part of pre-op optimization as well as post-operative and perioperative management, and our outcomes have proven that. We also have, this has helped us manage readmissions. Our readmissions have steadily streamed down, and readmissions are a huge initiative for our organization, as large as we are. When we think about our patient experience, we have seen our patient experience remain high in the 95th quartile here, presented here. When we think about complications, we have continued to trend in the downward direction regarding our complication measures. Again, all of this being data going through the last endpoint of CJR, a traditional program. The impact, we have had over 20 million in savings and revenue to date that has come from CMS with our success in this program, as well as shared savings from our health plan. Our hospital ratings are better, so therefore that results in better rates during the negotiating rates. Our academic investments, we've invested in our clinical programs. We have funded our adult reconstruction fellowship. We're investing in our academic programs. The research and analytics infrastructure that has come out of this has driven academic productivity, as well as manuscripts and grant applications across our programs. Investment, we invested in all these enhancements to build on the program, and it has been largely successful. When we think about an initiative that's specific to PT, we work with our home health partners, and we have UPMC Innovative Home Care Solutions. And they work with our service line, and we want to leverage our skill of our physical therapists, decrease unnecessary skilled nursing, review clinical data to determine number of visits for surgery. And so we developed this pilot in May of 2020. We used our very robust home health dashboard to determine which patients were getting care when, comorbidities, types of visits, how many of these visits are being delivered by physical therapy. And even prior to the Great Resignation and times of COVID, we knew that nursing utilization was of high value, physical therapy also high value, and has an ability to bridge that gap in these settings. And so 60% of nursing visits were not needed when we really looked at this across the continuum. And we had some hospitals and providers that were doing this quite well. And so therefore, it was a wide variation in the number of PT visits, no difference in outcomes were identified. And so therefore, we launched this. When we looked at parameters, UPMC Home Healthcare in our North, South, and Horizon branches, we piloted this with health plan insured patients, total knee, total hip, and total ankle surgery. We piloted across 2 hospitals and compared the same time to the previous year. And when we really looked at that, we had, again, surgeon champions. We used our physical therapy liaisons at each site, and they would essentially flag charts to say this person could be managed with home health with only PT, not nursing. And so we specify the number of visits. We would also provide telehealth visits. And also, if the surgeons felt something should be different, they could easily break the protocol. When we really looked at our home health visits over time, we had these 2 arms, and over time, we found at 90 to 91% of PT utilization versus skilled nursing. And so the average number of total home health visits decreased. The visit type, we had a larger drive toward the use of physical therapy and a decreased utilization of nursing, so that nursing could be used in other areas. Our hospitalization rates, rehospitalization rates decreased, also decreased nursing visits, and functional status improved or stayed the same despite a decreased number of therapy visits. And so we were generating even higher value and more efficiently. Other work included working with our skilled nursing facilities, telehealth investments and visits, as well as working with our MSK group. And we're expanding this since this time to spine and trauma. So a little bit on our Center of Excellence. We essentially built a Center of Excellence model with our health plan to where now if a surgeon wants to apply for criteria greater than 50 patients, greater than 300 procedures, and they meet those benchmarks, they can be a COE. All of these programs highlighted here in salmon or in yellow are essentially Center of Excellence programs within our health plan. We now developed a destination program for our joint program that our health plan as well as our hospitals market to payers, patients, and other providers. We now have a COE designation, which is now essentially a high quality outcome, low complication rate, and optimal patient experience driven program. This is now branded as our Platinum Care program, where we have a bundled program in that space. And our next steps are to continue to refine our finance and incentive models, reference-based pricing with employers, strive for excellence, and drive our patients to excellence. Our programs have been highlighted across the country in a number of domains, and we're very proud of this. This has been an enterprise-wide collaboration between our health plan, our quality center, as well as UPMC Enterprises, and again, our Center of Excellence partners in PT. So ideas for the path forward: you want to educate, integrate, engage, and execute, get things done that are very important to not only yourself, but your organization, and really building together, not having tunnel vision, and it's very important for us. So we follow our passions. It's the road not taken, and I like to say I took the one less traveled by, and that has made all the healthcare. Everything is happening in healthcare, and therefore we should consider being a Dyson. So I like to tell people, be high quality, but there are different types of Dysons, different costs, but they are their own vacuum. Engage, listen, discuss, and plan together, and maybe best apart, but better together. With great power comes great responsibility. It is a gift and curse, but we must take advantage of that. This is our gift and our curse. So life is short. If there was more of ever a moment to follow your passion and do something that matters to you, that moment is now, particularly in healthcare. And winners are not the people who never fail, but the people who never quit. So partners, and particularly my family. So remember what's important. And thank you, thank you, thank you.